Hi folks, today I want you to join me to discuss the clinical features as well as the treatment options for pericarditis using this very simple medical mnemonic, pericards. So not wasting much time, let's dive into it. But don't forget to hit the subscribe button. Chest pain is a major presenting complaint. Generally, the pain is pleuritic, intense, and sudden, sharp, or stabbing retrosternal chest pain, which is worse on inspiration or supine, but relieved by sitting upright and leaning forward. You do recall that the parietal pleura has somatic innervation, but the visceral pleura has no innervation. The pain may also radiate to the neck or arms or shoulders, just like in ischemic heart disease. When it radiates to the trapezius muscle, this is most likely due to pericarditis as the phrenic nerve runs through the pericardium. Now, it's very important to understand that the pain may also be dull and crushing or squeezing, as in ischemic heart disease, which may pose a challenge to discriminating pericarditis from ischemic heart disease. And in such cases, an extra workup would be indispensable. Electrocardiogram is extremely instrumental in the diagnostics of pericarditis, and among the features which are suggestive of pericarditis may include a diffuse ST segment elevation, which is concave upward, which is in contrast to the upward convexity that we see in myocardial infarction. Moreover, in myocardial infarction, the ST segment elevation is regional. In other words, we will see them in the anterior leads or the lateral leads or the inferior leads or a combination of these leads. PR segment depression is also very specific for pericarditis, and sinus tachycardia is quite common due to the pain, anxiety, and the pericardial effusion that may be associated with it. So this is a normal ECG. We have a P wave, Q wave, R wave, S, and we have a T wave. So P, Q, R wave, S, and T, right? Now, the reason why I put this diagram here is I want you to remember the PR segment, which is from this point up to this point. We call this distance right there PR segment. Okay, and this is what is of relevance to us because we are saying there is a PR segment depression. And also, I want you to note something called the J point, which is here. This is the J point. And whenever this part here on the diagram raises, we call it an elevation. So when we say diffuse ST segment elevation, you're most likely going to find the elevation in most of the limb leads as well as the precordial leads, V2 up to V6, as well as the limb leads, right? So let's take a look at this. If this is an ECG of a patient with pericarditis, then we're going to notice sort of this pattern. Okay, you have a P wave right there, then there is a PR segment depression, and then the ST segment elevation here is much more of a concave upward. All right, so this is our P wave. This is the Q wave, and this is R, and you can see the T wave. Now, what you notice is that there is a depression of the PR segment, which is quite specific for pericarditis. Moreover, I want you to take a look at this. The elevation, you can see the J point is right here, and the ST elevation is concave upward like this. When we say concave, it's like a smiley face. Okay, this is a patient that is smiling. Now, in contrast to myocardial infarction, we would see an ECG like this: P wave, Q. All right, now you notice the J point, that there is an elevation. Moreover, the ST elevation is rather convex. This is the face of a patient that is desperately in need for an urgent help. So this is convex upward, this is concave upward. Electric alternance is an alternating QRS amplitude in almost all the leads. This is a sign that the heart is swinging in a pericardial effusion. So you would notice an ECG with a pattern like P wave, in the QRS complex, right? Then the next one would be a different amplitude. Okay, then the next one would be similar amplitude like this. So you realize that there is this alternating amplitudes of the QRS. And this is a sign that the heart is swinging in a pericardial effusion. Pericardial effusion is an abnormal accumulation of pericardial fluids due to an underlying pathology. Please check out my other video for the causes of pericarditis. Any new or worsening pericardial effusion could be suggestive of an acute pericarditis. In pericardial effusions, the fluid may be a transudate or an exudate. Any frank blood certainly always requires an urgent evaluation for serious disorders such as aortic dissection, ruptured aneurysm, coagulation impairment, or a myocardial infarction. Tuberculosis classically presents with a serous sanguineous effusion. The factors that determines the clinical significance are 1. The rate at which the fluids accumulate. 2. The pressure in the pericardial space. And of course, the volume of fluids. Now, among all this, I just want to emphasize on the rate because it's important to understand that a 200 ml rapid accumulation can cause immense hemodynamic instability compared to, say, a 2000 ml that accumulates gradually. So the rate of accumulation is very, very important. Pericardial friction rub is a harsh, leathery, or scratchy, high-pitched sound on auscultation. And these friction rubs are pathognomonic, however, their absence does not exclude pericarditis. The intensity would vary on auscultation, hence a repeated auscultation may be necessary at different times. Signs of inflammation such as fever and elevated ESR or C-reactive protein may come in different variables. They are not specific for pericarditis, but they still seek to reduce the threshold for suspicion of pericarditis, especially when combined with information obtained from a comprehensive clinical history. Now the treatment options using the mnemonic cards. Colchicine. This inhibits tubulin polymerization, blocks mitosis, decreases leukocytic motility, and phagocytosis. They are used as first-line choice with non-steroidal anti-inflammatory drugs such as aspirin, indomethacin, and ibuprofen. They may also be used in recurrent pericarditis. Corticosteroids play a pivotal role in the treatment of pericarditis due to the anti-inflammatory properties, the decreased capillary permeability, and the immune suppressive role that they play. They must be used if patients do not respond to conventional treatment, but they must be used with caution and only after infectious causes are excluded. Aspirin, non-steroidal anti-inflammatory drugs such as indomethacin, ibuprofen are regarded first-line choice and are also recommended to be combined with colchicine, especially to prevent recurrence. They also offer some level of pain relief. Bed rest is encouraged in the acute phase of pericarditis. If patients find it very difficult to maintain a supine position due to the pain, then an armchair may be used. Athletes are also encouraged to stay away from extreme physical exertion in the acute phase of pericarditis. Surgical procedures to drain the pericardial space may be indicated. Amongst such procedures may include pericardiocentesis, pericardial window, or a pericardiectomy. Every effort must be done to find the underlying cause and treat. In many cases, the cause is either viral or idiopathic. Suppression of the immune system with immunosuppressive agents may be required if an autoimmune disease is discovered as the etiologic factor. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.